This is Dr. Paul DeGramji, Collegeville Family Practice, Collegeville, Pennsylvania. Today we're talking about gout, beyond the flare, implementing solutions for hyperuricemia goal achievement in the primary care practice. Our goals are, number one, to incorporate a treat-to-target approach and practice systems for achieving serum uric acid goal in primary care. Number two, expand the therapeutic armamentarium to reach the target serum uric acid by including new and emerging dual-action combination approaches. Number three, educate the patients regarding gout beyond pain relief and provide a focus on uric acid goals. And finally, establish a practical gout management workflow that includes the patient or therapeutic adherence and practice systems for long-term monitoring and management. So first, let's look at gout and the primary care provider. Most of gout is treated in primary care, in the primary care setting. And a recent audit showed that fewer than half of patients were achieving this target serum uric acid over a 12-month period by their primary care providers. And one other survey found opportunities for gout management and treatment, so that educating regarding the achievement of gout goals becomes important, and implementing office monitoring. So the serum uric acid, it should be measured every 6 months, and this is something that's very important to do for an office staff. Screening for comorbidities is also important because gout rarely occurs by itself. And finally, uric acid treatment, uric acid lowering treatment considerations, and proper monitoring is also very important. Let's look at gout risk factors. Gout rarely occurs by itself, and there are many comorbidities that can occur with gout, but also let's look at some of the demographics. Advancing age, men have a much higher probability of gout than women. Family history of gout, extremely extensive. Gout is a problem in most cases of under-excretion of serum uric acid, and this is quite hereditary. It's a primary renal problem. Obesity, certain drugs like diuretics, low-dose aspirin, and cyclosporin. Alcohol drinking, especially beer, not just because of the alcohol, but also because of the guanosine content. A high fructose diet, there's a specific reason why a high fructose diet will increase serum uric acid levels. Organ transplantation, thyroid problems, and finally, myeloproliferative disorders. Again, when we look at the comorbidities in gout, we find that it's rare that a patient will not have any. Look at the associations that were seen in this study done in 2012. Patients with no gout and no hyperuricemia were compared to those with gout and hyperuricemia with respect to hypertension, obesity, type 2 diabetes, nephrolithiasis, heart attacks, heart failure, stroke, and renal impairment. And it was found that those with gout and hyperuricemia were much more likely to have those conditions. Look at hypertension specifically. It's about 3/4 of the patients who have gout and hyperuricemia have hypertension versus the general population with no gout. Obesity, more than half of those with gout and hyperuricemia. Diabetes, about 1/4 of them. Kidney stones, about 1 out of 5. Heart attacks, 10% versus only 2.5%. You can see that gout and hyperuricemia substantially has an increased rate of these comorbidities. Now, obviously, we're not talking here about causality, but certainly there is a lot of discussion as well as research going on to find out which causes which, if any at all. Let's break this down to chronic kidney disease. It turns out that 71% of U.S. patients with gout have stage 2 or higher CKD. And the annual reduction in GFR is astounding in these patients that have hyperuricemia and gout, where with healthy adults it's between 0.8 and 1.3, and those with untreated hyperuricemia in adults is 2.5. So there's a significant association between hyperuricemia and CKD. In fact, if you refer your patients to a nephrologist, they will almost always do a uric acid level. Let's get back to the primary care provider. and in treating hyperuricemia. In this study recently, about half of primary care providers will provide optimal medication therapy for acute gout attacks. Not too good, but not too bad. But really dismally, less than 1 out of 5 PCPs recommend optimal treatment for tophaceous gout, and about the same, 1 in 5 or less than that, of primary care providers use uric acid lowering therapy with dose titration and prophylaxis. A lot to be learned and a lot to be changed in primary care. Now let's step aside and review a little bit of the facts of gout and some of the statistics. It's the most common inflammatory arthritis in adults in the Western world, characterized by, of course, high uric acid levels and effects of acute and chronic inflammation in joints and even bursas. It's quite devastating in what it can do as one ages with the type of destruction it can cause to joints. Of course, it's caused by inflammation and the inflammatory response of monosodium urate crystals from hyperuricemia. The uric acid crystals are often encapsulated by protein and are scattered throughout the synovia, but at some point the protein can slough off and cause a tremendous amount of uric acid crystals that are bare to cause massive inflammation, causing an agonizing pain in one joint, typically in the colder joints of the body like the knees, feet, and toes, and even fingers and wrists. However, there's new hope for patients with new discoveries, and things are changing, and this is important to note going forward. Again, in review, where does uric acid come from? Well, we all know that it's a breakdown product of purines. The great majority of the uric acid in our blood comes that way. Some of it is absorbed through food, but you can see here that when purine is catabolized, it is broken down to hypoxanthine, and using a enzyme called xanthine oxidase, hypoxanthine is converted to xanthine, and the same enzyme then converts that to uric acid. Most mammals, they also have uric acid oxidase or urate oxidase or uricase, which converts uric acid to allantoin. What's the significance of this? In humans and in great apes, this uricase is missing. As a result, uric acid accumulates. Allantoin is extremely soluble, whereas uric acid is very insoluble and can crystallize. In fact, it can crystallize anywhere in the body. It has a tendency, though, of course, to cause the tremendous pain that occurs in joints when the crystalline form causes the inflammation. It should be noted that these crystals that cause tremendous amount of pain can be seen under the microscope under plain polarized light, as seen in this slide. Of note also is that uric acid crystallizes at a concentration of 6.8 milligrams per deciliter in normal pH and temperatures. In lower temperatures, such as in the joints of the toes, ankles, and knees, wrists, and fingers, it crystallizes at lower temperatures. There is a higher probability of gout occurring in those joints. Let's get back to treatment. This treat-to-target dilemma. Serum uric acid treatment initially will increase flares. We all know this when we treat patients with hyperuricemia. And the reason for that is because the uric acid crystals that are encapsulated in protein, these microtophi in the synovia, when the uric acid level in the serum reduces, the uric acid crystals will slough off and they will go into joints as they're going into serum to be dissolved. This process where the serum uric acid is going down and the uric acid crystals are going up in joints will cause these massive flares. Now, eventually, the patient will have no uric acid left in the joints and no flares will occur. But initially, it's very important to know that this can happen. And that's why we use prophylaxis against these gout attacks. Well, of course, some primary care providers may not do so, and patients may not know to do so. And as a result, when they get these flares, it may cause the patient not to treat their serum uric acid level to target by simply not taking the medication. Also, suboptimal treatment of serum uric acid can lead to more flares every year. The optimal treatment is to get the serum uric acid level to below 6.0 milligrams per deciliter, and in tophaceous gout to reduce it to even below 5. So in the long haul, treat to target is recommended for reduction of flares and prevention of joint destruction. We all should keep in mind that as the years go on with patients with gout, they have significant morbidity and disability as a result of gout, with the joint destruction going on, the joint pain going on. If you've ever seen a patient in his 50s or 60s who's been having gout attacks for years, the osteoarthritis, the degeneration of their joints, is quite significant. It can certainly increase healthcare costs and may even cause some hospital admissions. Patients oftentimes, because of the severity of the condition of an attack, will go to an emergency room and possibly even hospitalized for a joint pain that's so severe that maybe the clinician thinks it could be a septic arthritis. Now let's look at the American College of Rheumatology treatment guidelines. They suggest with a gout arthritis attack to treat the flare as soon as possible. They say within 24 hours, but you may even want to treat it within 24 minutes or so because time is of the essence. You want to reduce pain, inflammation, and disability as quickly as possible. The earlier the inflammation is reduced, the quicker it will go away and the easier it will go away. And as we all know, the first-line options for treatment of an acute flare is nonsteroidal anti-inflammatory drugs, and any of these can be effective. We will typically choose a high dose of something relatively rapid-acting and also affordable, something like ibuprofen or indomethacin or naproxen. We can also choose colchicine in the newer dosage, which is the 1.2 milligrams initially, followed by another 0.6 milligrams given in 1 hour. Glucocorticoids can also be used either parenterally or intra-articular. They can also be given, of course, orally. Combinations can sometimes be used in very difficult cases in certain patients. Now, I've mentioned treat to target. And what do we really mean by this? What we're trying to say is to get the serum uric acid level so low that the uric acid then is leaving the body and continues to leave the body until eventually no uric acid is left in the joints that can cause attacks. And to do this, we need to get the serum uric acid level to a point where the crystals can dissolve, and we would like to get them below 6, as we discussed earlier, below 6 milligrams per deciliter and below 5 in tophaceous gout or infrequent attacks. So serum uric acid, therefore, has to be measured. Initially, when you are lowering serum uric acid level with whichever means, you will titrate the medication and want to get that patient to the target of below 6, and of course continue to monitor. And there are some guidelines on how often these levels should be monitored. So again, why does treat to target or treat to goal of serum uric acid matter so much? Well, for one thing, of course, by reducing these gout attacks, you're going to improve the quality of life. You're going to improve the patient's abilities, reduce pain, reduce disability. But also keep in mind that as the months and years go on, that uric acid is destroying the joint. So joint destruction is lessened as a result of all this. Also, we should keep in mind, as we discussed earlier about comorbidities, that there's a strong association between gout and metabolic syndrome. Now, does serum uric acid lowering help with this? More to come. We've also talked about serum uric acid level being elevated in gout being an independent risk factor for cardiovascular disease and even mortality. So does lowering serum uric acid help with these? Again, more to come. So now that I've spoken on the importance of treating to target, well, how do we actually do this? Well, for one thing, knowing about gout is important, and therefore you want to put it on your radar. When you know that gout is important to identify and treat because of what we discussed earlier, you will make a point of looking for it and identifying it and treating it properly. And know that treating an acute attack is never enough. That if somebody has one attack, they've been having elevated serum uric acid level probably since their teens. And the gout or the uric acid that's causing gout has been accumulating in their system for years. And know that getting the serum uric acid to below 6 milligrams per deciliter or below 5 when there's tophi is the target. And following up with testing every 6 months or even more in patients who've been stabilized with medication is very important. You also have to know how to use the pharmacologics, both the traditional and some of the new and emerging ones, for optimal results. And know that more than 25% of patients will need combinations of meds to achieve their goal. All right, so now let's talk about some of these methods to reduce serum uric acid. Well, the most commonly used ones are xanthine oxidase inhibitors. If you remember the slide earlier, I showed you about the enzyme xanthine oxidase, which converts the purine all the way to uric acid. Inhibiting xanthine oxidase will prevent the development of uric acid, most commonly. And if we look at the most common one of these, allopurinol, it's been around for over 60, 70 years, available in the United States and in the rest of the world. It's got a purine-like backbone. It's converted in the liver to oxypurinol, has quite a long half-life, about 24 hours or so. It can be dosed once a day, but for GI reasons, a lot of times we want to break it up and dose it twice a day. So the starting dosage is 100 milligrams, and it should be no greater than that, and it should be even less in moderate to severe CKD. Gradual up titration, and there's different variations on exactly how gradual this should be, whether it should be changed every 2 weeks or 4 weeks, and eventually to reach a maintenance dose. And this can exceed 300 milligrams even in patients with CKD. In this country, United States, the maximum dosage is 800 milligrams, and in Europe it's 900 milligrams. So this is the most common uric acid lowering therapy, as we discussed. There are some problems with it. We all know about the possibility of a rash occurring in about 2%. Some patients have intolerance, primarily GI intolerance, or maybe even hepatic enzyme elevation. Some CNS symptoms may occur. This occurs in 5 to 10%. Some major cutaneous reactions have occurred, like Stevens-Johnson syndrome or TEN, which is toxic epidermal necrolysis. This is linked with a specific HLA, the HLA-B58 gene, and in fact it can be tested for in certain populations that have an increased risk of this happening. There's also major allopurinol hypersensitivity syndrome, and it's been reported to occur at 0.1 to 0.4%, but it does have a pretty high mortality of 25%. And again, reviewing the dosage guidelines, start with 100 milligrams daily, lower in chronic kidney disease, increase by 100 milligrams every 2 weeks or so until the target serum uric acid level is reached. And at 400 milligrams, we want to break this down to twice a day. And 400 milligrams, by the way, is the average dose where serum uric acid level is usually going to be achieved at the target level. Allopurinol dosage adjustments required in chronic kidney disease, and as we discussed earlier, the FDA-approved dosage in this country is up to 800 milligrams. As said earlier, in certain populations, there is a higher risk of developing the major sensitivity that we've talked about. And Koreans with stage 3 or worse CKD, Han Chinese, and Thai, you might want to get an HLA-B5801 screening for risk management. In these patients, you don't want to use this medication. The other of the two xanthine oxidase inhibitor is febuxostat. It's a non-purine, chemically completely different. It does inhibit xanthine oxidase, but in a completely different way. It's got a non-purine backbone and selective inhibitor of xanthine oxidase, primarily metabolized also in the liver. Let's look at these two xanthine oxidase inhibitors, specifically febuxostat phase 3 trials versus non-titrated allopurinol. Confirms trials showing that febuxostat 40 milligrams got patients to target, and the target here being less than 6 milligrams per deciliter, 45% of the time. Febuxostat 80 did it 2/3 of the time, compared to allopurinol 300 milligrams, 42% of the time. In the APEX trial with febuxostat, only 80 milligrams was attempted here. About 3/4 of patients got the target versus, again, about 40% of those with allopurinol 300 milligrams. The FACT trial showed that about half the patients on febuxostat 80 milligrams got patients to target versus only 1 out of 5 in the allopurinol 300 milligrams. So again, in maximum dosage febuxostat, you're going to get at best maybe 3/4 of your patients to target. And with allopurinol 300 milligrams, which is the most commonly used dosage in this country, less than half of the patients are going to achieve their target level. Now let's go to febuxostat dosing. Labeling is 40 milligrams to be started on patients, and after 2 weeks, if the serum uric acid level is not at target, then you can increase it to 80 milligrams. And that's the only two dosages that are approved in this country. Dosage reductions are not needed in moderate renal or liver impairment. The most common side effects are rash, about 2%, pretty much the same as with allopurinol, some elevated LFTs, about 3%, and some arthralgias. In Europe, by the way, the maximum dosage is 120, and interestingly, the American College of Rheumatology says that we can use it up to 120 milligrams. Again, this would be off-label, this dosage in this country. We've talked about chronic kidney disease and gout and hyperuricemia. Interestingly, in some of the data that we have on febuxostat, there seems to be some preservation of renal function when febuxostat is used. Specifically in these patients, and going up to several years, there's actually even improvement in their eGFR initially before the continued deterioration. So maybe, again, a causal relationship between hyperuricemia and chronic kidney disease. So we've talked about xanthine oxidase inhibitors, and this would be considered suppressing the uric acid formation or uricostatic. But we should also remember that there is also uricosuric medications which increase uric acid elimination. For example, through targeting the proximal tubules in the epithelial cell transporters using probenecid. This is one method. There's also a uricolytic or biologic approach. Remember in the formula I showed you earlier where uric acid goes to allantoin using uricase, we can actually make uricase and peglate it, which is called pegloticase, and this is intravenously given in an infusion center, which can completely dissolve uric acid or convert uric acid to allantoin. Very dramatic reductions in serum uric acid. And getting back to probenecid, which is uricosuric, it's one of the 2 FDA-approved agents currently available. The typical dosage is 500 milligrams twice a day, up titrated up to 2.5 grams a day. Usage is first line only if xanthine oxidase inhibitors can't be used. Typically, it's second line added to an XOI if the target isn't reached. It's not effective with a GFR less than 50. It's actually contraindicated in patients with uric acid overproduction. Its activity can be blocked by aspirin, and some of the common side effects include kidney stones, non-specific GI and CNS side effects, rash, and drug-drug interactions. The other of the 2 uricosuric agents available is lesinurad. It's a selective uric acid reabsorption inhibitor. It's approved as an add-on, so you can give it to patients who are on allopurinol or febuxostat. Lesinurad also does come in a combination with allopurinol as one pill. Some of the recent data with lesinurad as a selective uric acid reabsorption inhibitor, CLEAR 1 and CLEAR 2 trials with allopurinol showed a substantial improvement or reduction in serum uric acid levels, so that a greater portion of patients got to target with it than those who took placebo on top of the xanthine oxidase allopurinol. Combining uric acid lowering therapies is an advantage and necessary in many cases because many xanthine oxidase inhibitors, both of them that we've discussed, often do not achieve a serum uric acid level below 6 or even below 5, and therefore we need to use this add-on. Combination therapies, therefore, being very common in primary care, using 2 methods of action. Mechanisms of action for medications can often be an advantage in some cases. And again, to show more data on this, with lesinurad in combination with allopurinol achieved a serum target below 6 at 50% or so in CLEAR 1 and CLEAR 2 versus placebo at around 28% to 23% in CLEAR 1 and CLEAR 2 respectively. And also interestingly, in the subpopulation with patients with renal impairment, this similar kind of improvement was found as well. About or more than half got their serum uric acid to goal with lesinurad plus allopurinol compared to placebo at around 29 to 32% respectively. Studies have also been done with lesinurad and febuxostat, and again, substantial patients will get to target with the combination medication. Resolution of tophus was also part of this clinical trial as a secondary endpoint. The trial went on for 1 year, and during that time there was some resolution of tophi, but as we know, in order for a tophus to dissolve and go away, it does usually take much longer than a year. A word about safety and lesinurad. Because there is a risk of acute renal failure, with lesinurad alone, it should only be used in combination. Dosage on lesinurad is 200 milligrams. There's only one dosage form, taken either with allopurinol or febuxostat. And as said earlier, there is now a combination of lesinurad and allopurinol in one pill. It has 200 milligrams of lesinurad and either 200 milligrams of allopurinol, or another formulation is with lesinurad 200 and allopurinol 300 milligrams. This medication requires no dosage adjustment for mild or moderate renal impairment with creatinine clearances equal to or greater than 45 milligrams or milliliters per minute. For moderate to severe CKD, creatinine clearance is 30 to 45. It's not recommended that you initiate this medication. And severe renal impairment, it's contraindicated. I should also mention that there are other medications that have a tendency to be uricosuric as a side note to the medication. So losartan, fenofibrate, atorvastatin, these have, of course, other functions other than uric acid lowering, but they are all uricosuric, and they may help in uric acid reduction. Of course, using these for uric acid reduction is off-label, but it may be a good option in certain cases of patients who have need for this medicine and also have uric acid elevation. Let's now look at patient perceptions and provider perceptions. Turns out, in this study at least, that providers view gout medication adherence as quite good. They think their patients are taking the medication and doing well. In actuality, in this study, gout medication adherence was quite poor. About a third of these patients were using the medication properly, and patients seemed to discontinue gout medications because they thought that uric acid lowering treatment would worsen their gout, because they would see that initially maybe they were getting a lot more gout attacks and they were not educated. They also did not seem to recognize or realize the long-term value of getting rid of uric acid out of their system that had been accumulating for so many years. And discontinuing the therapy sometimes would occur as a result of cost concerns or just simply not wanting to take medication. So patients did not seem to have enough information to make an educated decision. So again, patients did not seem to understand this concept of treat to target. And that really, for the most part, falls into the lap of the primary care providers, which need to offer this kind of education for their patients. We've talked a lot about medication. Why don't we just step back a second and address what you might be thinking about, and patients also do, which is, well, what about dietary changes? What can patients do to lower their uric acids naturally? Well, weight loss is actually one of the most effective ways. We find, for example, that patients who are morbidly obese and have massive weight reduction with bariatric surgery, their uric acids can drop dramatically. But really, a modest weight loss of 5 to 10% can actually reduce uric acid appreciably. Reducing or eliminating alcohol, specifically beer, is a good idea. Drinks or beverages that have a lot of fructose is also not a good idea, and limiting them may be important. Drinking a lot of water, also very important. Increasing plant-based proteins like beans and legumes, and avoiding high purine foods like organ meats, oily fish, and some other vegetables are a good idea to ask your patients to do. We should note, though, that at best, patients will lower their serum uric acid levels by maybe 1 milligram per deciliter if they work their hardest in these dietary recommendations. So often, a patient will not be able to achieve a target serum uric acid level simply by lifestyle changes. And what is a presentation on any medical condition without looking at the economic negatives, particular problems, specifically here uric acid, and also the benefits of achieving gout goals? Some studies have shown that there can be a substantial gain financially to the population and to the patient when serum uric acid level is treated to target. As I said earlier, Patients' lack of knowledge of this condition often leads to inadequate treatment. So we need to have our patients have a clear understanding that this is a progressive condition with serum uric acid accumulating when not at target. Untreated elevated serum uric acid results in chronic joint damage, progressive joint damage, and treatment options and duration of therapy for acute gout and chronic gout must be shared with patients so they can make an educated decision. So the concept of uric acid lowering therapy to avoid complications and disability is very important to pass on to our patients in the best way we know on how to educate them. So this treatment to goal, treatment to target, we know this with our patients. We educate them for, let's say, diabetes and their A1Cs, and blood pressures and the specific numbers, and cholesterol and their LDL numbers. We tell them what their targets are. They know the numbers they need to achieve. Patients also need to know their target numbers for serum uric acid. So in order to do this, in order to achieve it, we obviously have to engage the patient, discuss with them, spend enough time so they know what's going on. And because we have many opportunities to discuss with patients, one should take the opportunity on many visits to review and go over and make sure the patient has a clear understanding of why uric acid and gout is being treated and recommended to be treated in the way that you want them to. So to summarize patient education goals, we need to discuss with them what gout is, serum uric acid, our treatment goals, long-term consequences, and how to avoid them by treating to target, and also their contributions to the gout problem and high uric acid levels with exercise for overall health, joint mobility, weight maintenance, diet, and medication adherence tips. These are all important to review with our patients. As a reminder, we have some physical activity goals as per the Center for Disease Control. Physical activity improving arthritis. And adults are recommended to have 150 minutes of moderate intensity exercise per week, plus some muscle strengthening 2 or more days per week. Older adults, 150 to 300 minutes of moderate intensity per week, plus muscle strengthening. And physical disability issues, by the way, if you have it in your patients, as I always do, I try to get them to physical therapists who can teach them the right way on how to do things. This is oftentimes time well spent for patients. We talked about diet earlier. Let's review again. It's important for patients to know to avoid organ meats such as breads and liver and kidneys, which have a high purine content, high fructose corn syrup, or high fructose anything, sweetened sodas, other beverages and foods. Alcohol, specifically beer, is a very important one to try to avoid. Any alcohol can be a problem, but again, because of the guanosine content in beer, that is especially necessary to avoid. Limiting certain food products are also important for them to recognize as listed in the middle column. Encouraging, by the way, low-fat or non-fat dairy is a good idea. Vegetables, cherries, also plenty of water. And one other that's not on here is coffee. Seems to be quite useful in reducing uric acid and gout. So let's finish up by discussing the management of the gout patient long term. We talked earlier about using uric acid lowering therapy. And when we use these medications, we need to know about preventing flares during the early years, months, specifically 3 to 6 months. This can be done by either colchicine or NSAIDs or sometimes even glucocorticoids. We have to maintain normal serum uric acid levels with long-term uric acid lowering therapy medication. And normal serum uric acid levels, the targets are below 6 milligrams per deciliter in most patients and some below 5. We need to discuss with our patients diet, lifestyle modifications. They have contributions in all this, as well as, of course, adhering to medication and getting blood testing done and following up as per your instructions. We have to monitor side effect status of flare medications as well as uric acid lowering therapy medications. We discussed earlier follow-up, but specifically, we want to have the serum uric acid levels measured regularly every 6 months. And finally, when we do these blood tests, oftentimes it is a good idea to check their kidney functions and even sometimes check their liver function tests.